prevent any excess bleeding. There's several needles and syringes. There's a
Right. We'll start later. Good morning. Can you hear me?
Yes,
Good
sir.
morning.
Okay, right. Thank you so much. Right. Right. Good morning once again. We have about 30 people who have joined in. Anyway, as the initial part is just an introduction, so I'll just start and go on. So how I plan to do today's session is, so I thought of dividing it into two parts. In the first part, I hope I'll be able to finish it in time less than 1 hour. So I'll be just talking to you about the spinal cord and the brainstem and the clinical conditions. Right. So I have gone through some of the past paper questions that Dr. Kanira sent to me. But then what I saw is basically the most of the questions that you are getting is um, are clinically related. So they are based on the clinical scenarios. So where you have to apply the neuroanatomy knowledge into describe the clinical effects in different types of CNS injuries, right? Um, so I'll be focusing on those as well, or those aspects, but giving you the basics as well, helping you to revise. I know that you have learned all these in your undergraduate studies, right? So this is going to be like in previous sessions. So this is going to be a very quick revision, right? Just helping you to revise and just brainstorm what you have already learned, right? Yeah, so we'll start. So in this first session, as I told you, so I'll be focusing on the very briefly. I'll tell what the nervous system is, what are the different parts. So then go into the basic anatomy of the spinal cord, right? And then the different tracks, the ascending and the descending tracks, and then the clinical anatomy of the spinal cord, the clinical effect. Yeah. The clinical effects of different types of spinal cord injuries, right? So then we'll go into the brain stem. In your past papers, I didn't see, I just have a few questions. I didn't see the occasions where you are asked to draw the cross sections of the brain stem. But that is, I think there is a possibility because there were just 2 or 3 questions, essay questions I saw, right? Um, because that is something that we ask even the undergraduate students to do, and having the knowledge of the different structures at each level of the brain stem helps you to describe the different clinical effects of brainstem injuries. So I'll just very quickly tell you how to draw this brainstem with the real idea rather than just memorizing a picture, right? So how to draw it with some purpose and with the real knowledge, right? So then about the common clinical conditions affecting the brainstem. So hopefully I'll be able to finish this before 1 hour. So then we are in the second session, we'll go into the higher part, the cerebrum, the cerebellum, the thalamus, the smaller topics like thalamus, hypothalamus. I'll not be spending much time on those, right? But basically about the cerebrum and the blood supply. And if time permits, I'll just very quickly go through the cranial nerves as well. Otherwise, I'll share the note that I have prepared because it is mostly remembering the facts about the cranial nerves, right? Nothing much to discuss as such, right? Right. So, very quickly, right? Just take 5 minutes to look at what the nervous system is. We know the human nervous system has a central part, central nervous system, and the peripheral nervous system.
document என்னத்த இருக்கு
The peripheral nervous system
So,
can
உனக்கு
be
basic
divided
document எல்லாம் கொடுத்துட்டியா
into the sensory division and the autonomic division, right? Sorry, sensory division and the motor division. And the motor division has a somatic motor part which innervates our skeletal muscles, and the autonomic part which innervates the cardiac and the smooth muscles and the different glands, right? So, so that is the general organization. You just know I will not spend time on this. So as in the previous occasions, I used the set of lecture slides that I use for the undergraduate. So some of these will be very basic. And then the brain itself has so many different components, the cerebrum, the cerebellum. There are internal structures like basal ganglia. Then we have the diencephalon, that is basically the thalamus and the hypothalamus. So all that is collectively known as the brain, right? So basically in the central nervous system, we know that the cell bodies are arranged in areas which are known as gray matter, and the nerve fibers, so the tracks, are arranged in the white matter. And the arrangement is different in the brain and the spinal cord. You can see, that in the spinal cord, the cell bodies are in the center and the tracks are at the periphery. And it is the reverse in the case of the cerebrum. So then the central nervous system is lined by 3 coverings, the meninges, the dura, arachnoid, and the pia. Right. I'll just mention with each section. I'll just tell the specific things about this. Right. And then the entire CNS is bathing within the cerebrospinal fluid, the CSF, which is filling the subarachnoid space as well as the ventricular system. Right. So we have a set of cavities in the central nervous system, which is filled with the subarachnoid CSF, cerebrospinal fluid, and this ventricular system, which is somewhere in the center, it communicates with the subarachnoid space through three foramina in the fourth ventricle. So that is the two lateral apertures. We call them the foramen of Luschka, and there is a median foramen, that is the foramen of Magendie. How I remember this as a student is the lateral ones are Luschka, that is L for L, and the median one is a Magendie, right? So those are the three foramina which connects the ventricular system into the subarachnoid space. Right, so this is how these ventricles are arranged. You know that there are two lateral ventricles in the cerebrum, within the cerebral hemispheres, and trapped between the two diencephalons, the thalamus and hypothalamus on either side. So in the midline, you have the third ventricle, right? So then we have the fourth ventricle in the region of the pons and the upper medulla, and there is a connection between the third and fourth ventricle, which is known as a cerebral aqueduct. So then our eyes, beginning from the fourth ventricle, going down the lower medulla and the spinal cord would be the central canal. So this entire system is again filled with the cerebrospinal fluid, right? Yeah, so then about the peripheral nervous system, I told you that you know that there is a sensory and the motor division. The somatic motor division innervates skeletal muscles, while the autonomic nerve division innervates the cardiac and smooth muscles and the glands. And this peripheral nervous system, so it contains 12 cranial nerves, the 31 pairs of spinal nerves, lot of somatic nerve flexors. You have learned about the brachial flexors, cervical, brachial, lumbar, and the sacral flexors, right? And also a lot of autonomic plexuses as well as the different ganglia, right? So we'll just very briefly talk about cranial nerves later, right? So then the spinal nerve, the 31 pairs. So you know how they are arranged, and the different nerve flexuses. So all these are the components of the peripheral nervous system. And additionally, you learn that so there is a sympathetic and the parasympathetic nervous system. The sympathetic nervous system, it has the outflow from the spinal cord from the T1 to L2. Generally, it is beginning from T1. So because the sympathetic chain, you have learned that the sympathetic chain do not have direct connections with the spinal cord in the cervical segments. So everything which is ascending into the cervical sympathetic chain has to go along the spinal cord, leave the spinal cord through that first thoracic spinal nerve and goes upward, right? So then the parasympathetic nervous system, it has a cranial outflow which is coming from the third, seventh, ninth, and the 10th cranial nerves, and the sacral outflow, that is from these 2, 3, 4 segments, right? So those are the different outflows of the parasympathetic nervous system, and you know what the sympathetic and parasympathetic nervous systems do, right? Yeah, so there is a very quick revision of the outline of the nervous system. So we'll move into the main topic, the spinal cord first, right? So basically, you know, the spinal cord extends, it is a continuation of the medulla, which is beginning at the foramen magnum and ending in an adult at the L1 vertebral level, that is a transpyloric plane, right? But in a newborn, so it will be extending up to the L3 level, right? But you know, when the newborn starts walking and the standing, there will be the secondary curvatures of the spine that are appearing, because you know the newborn has a very curved back. But when the other curves, the cervical and the lumbar curves appears, the spinal cord is dragged upward, so it will move up to the L1 vertebral level. And this is covered by the three meninges, the pia, arachnoid, and the dura. The pia mater lines the surface of the spinal cord, and when the spinal cord ends, it extends as a small filament, which we call the filum terminale, which attach the spinal cord to the coccyx. And the dura and arachnoid goes together up to the level of the S2 level. So between the termination of the spinal cord and the termination of this dural sac, there is generally a long gap which is filled with the cerebrospinal fluid. And you know that is the area that we use to take the CSF samples through lumbar puncture, right? So going into the more the external appearance. So you know the spinal cord has two enlargements in the cervical part and the lumbar part. That is basically because these regions gives off lot of motor nerves to the muscles of the limbs, as well as receives a lot of sensory information from the limbs, right? So that is why generally you know these cervical and the lumbar part, so those are the area which uh, gives origin to the brachial plexus as well as the lumbar plexus, right? So that is why these regions of the spinal cord are enlarged, right? So looking at the low end of the spinal cord, you know, towards the end, the spinal cord tapers off as the conus medullaris, and there will all the so it is ending at the L1 level. So the lower lumbar nerves and the sacral and the coccygeal nerves has to go down from this termination of the spinal cord. And these all the spinal nerves in the lumbar, sacral, and the coccygeal segments, they collect to form a structure which looks like a horse tail. So that is the coda equina, right? So then still about the gross anatomy of the spinal cord, we learned that the spinal cord is attached to the coccyx through the filum terminale, that is an extension of the pia. And there are other extensions of the pia mater which holds the spinal cord into the adjacent vertebrae, right? So so those are known as a denticulate ligament. So these are things. So these structures are important to keep the spinal cord stable within the spinal canal of the vertebral column, right? Right. So then, of course, you know the spinal cord has these 31 segments. One important thing you need to remember is as the spinal cord is shorter than the vertebral column, the vertebral levels are directly not, they are not at the direct level as the spinal cord levels, right? So we use the general something, a formula like thing. So if it is upper cervical, so it would be at the same vertebral level. So think if it is the C3 vertebra, so what you find there would be the C3 cervical spinal cord segment. But if it is a lower cervical one, right? So it will be one vertebral level above. So that, for example, the seventh, right? The seventh cervical spinal cord segment will be at the sixth cervical vertebral level, right? So then if it is upper thoracic, we add 2. If you want to find the vertebral level, we subtract 2, right? So that means T5 is in the 3 level, right? If it is lower thoracic, if it is T10, it would be in the T7 level, right? So if the spinal cord segments T12 will be somewhere around the T9 level, right? So then all the lumbar segments would be from T10 to T12, right? And the L1 level, the terminal part, so that will be having the sacral and the coccygeal segments. So this is clinically important because generally when a patient comes with the spinal injury, so when we do the investigation, the radiological investigation, what we see is the vertebral injury commonly. So depending on the vertebra which is affected, we should be able to tell. So probably this would be the level of the spinal cord lesion, right? Because the vertebral level, does not directly, it is not directly tying with the spinal cord level. So having an idea about this, so this is not a hard and fast rule, right? But it is generally in the clinical settings, we use it to uh, demarcate the vertebral, the spinal cord levels that corresponds to the different vertebra, right? Right. So then we'll move into the internal structure. So you know the spinal cord has a central gray matter which looks like an H, right? And with the surrounding white matter. The gray matter contains the nerve cell body. So that is why it appears gray, because it does not have myelin around the cell bodies. But the white matter has a lot of myelinated neurons, so it appears whitish in color, right? So if we look at the different areas, you know, the gray matter has three horns: the posterior, anterior, and a lateral gray horn. And the lateral gray horn is not present throughout. Lateral gray horn is the autonomic area of the spinal cord. So that is where you find the autonomic neurons, right? So and you know the sympathetic outflow is from to T1 to L2, and the parasympathetic outflow from the spinal cord is from S2, S3, and S4. So we see the lateral gray horn only in these areas. So that means in the cervical segments of the spinal cord, you will not see a lateral gray horn, right? So then we have the white matter, which is again divided into posterior, lateral, and the anterior white columns, right? And they contains the myelinated neurons, the ascending and the descending tracts, right? So if you look at the structure of these different gray horns, the posterior gray horn is the part which receives all the sensory neurons from the posterior nerve root. So generally the cell bodies of all the sensory neurons lies in the posterior root ganglion, right? And the posterior gray horn contains the cell bodies of the second order neurons of the sensory pathways. And the collections of neurons within the central nervous system, they are known as a nuclei. So you have different nuclei: the nucleus dorsalis, nucleus proprius, substantia gelatinosa. So there are so many, but I just mentioned a few things that is important for to describe the different tracks, right? And then I told you the lateral gray horn is the intermediolateral set. So that is a autonomic that is a collection of the autonomic neurons, right? Cell bodies. And then the anterior gray horn mainly has the multipolar neurons of the lower motor neurons. So they are generally multipolar type, right? So that is where the lower motor neurons begins.
Priyadarshini.
Right. So yeah, if you have any questions as we go on, sorry, just type it in chat box, right? Or you can just excuse and ask the questions, right? These you might not be having much question because this is the basics, right? So this is about the arrangement or the structure of the gray matter, right? So then we move into the white matter, which contains three columns: the posterior, lateral, and the white columns. And this contains the ascending and the descending tracts, right? So we describe it as three sets. So the posterior column has a fasciculus gracilis and fasciculus cuneatus. So then we have two spinothalamic tracts, the lateral and the anterior ones, and the two spinocerebellar tracts, right? So we look at them here separately. The descending tracts, so there are many descending tracts, right? So what is important for the voluntary movements are the corticospinal tracts, so which is coming from the cerebral cortex to the spinal cord. So we have a lateral corticospinal tract, which is the largest one, which contains about 90% of the neurons, right? And the anterior corticospinal tract, which has a smaller contribution. So remember, in addition to all these, there are a lot of extra pyramidal tracts. So these two are known as pyramidal tracts because they are rising from the pyramidal cell layers of the cerebrum. going through the pyramids in the brainstem, right? So we call them the pyramidal pathways, but additionally, there are several extra pyramidal pathways. I'll just mention about that as we go on, right? Yeah, so just have a look at each of these tracks separately because that is important to identify the clinical relevance of these. So if we look at the posterior column, the fasciculus gracilis and the fasciculus cuneatus, so they contain the uncrossed first order neurons, right? So that is a first order neuron, the same neuron which is arising from the receptors, right? And they carry the kind of a higher order general sensation, the proprioception, vibration, the discriminative touch, right? So that kind of a higher sensory, general sensory information which need a bit of a higher discrimination, right? So those goes in the posterior column, right? And remember, what is important is you need to know that they carry the information from the same side of the body because they are uncrossed neurons. But in contrast, the spinothalamic tracts, you can see they have the cross neurons and they are the second order neurons. So the first order neuron ends in the substantia gelatinosa and the second order neuron crosses to the opposite side. So if it is related to the pain and temperature, it will go into the lateral tract. And if it is regarding the crude touch, the light touch and the pressure sensation, so it will go into the anterior spinothalamic tract. Right? So those are the conscious sensations that we get through the spinal cord. So they have two different pathways, right? So fasciculus gracilis and cuneatus, you can see it is a first order neuron which ascends up to the lower medulla, where they ends at the nucleus gracilis and the nucleus cuneatus, and the second order neuron immediately cross to the opposite side. And they go into the VPL nucleus, ventral posterolateral nucleus of the thalamus of the through the medial lemniscus, then through the posterior limb of internal capsule and the corona radiata to the sensory cortex in the parietal lobe. Right? So that is this proprioception, vibration, those type of pathways. Then pain, temperature, touch and pressure, light touch and pressure, they comes in the spinothalamic pathways where the first order neuron ends in the spinal cord. They cross to the opposite side, not at the same level. There is kind of an oblique crossing of these tracks. So then they ascend through the brainstem as the spinal lemniscus, and they beyond that. So from the thalamus level, so they have the same pathway as the posterior column from VPL nucleus, posterior limb of internal capsule, corona radiata to the sensory cortex. So that is the same conscious sensory pathway. But then you know that we have a lot of unconscious sensation, the sensation that we are not aware of, which helps to keep the body in balance, to maintain the posture. So that is the spinocerebellar tract, because the cerebellum is concerned with maintaining this posture and the balance, and it constantly receives information from our muscle spindles, Golgi tendon organs, so gives some information of the position of the joints. Unconscious, we are not really perceiving that, but the cerebellum receives that information through two tracts. So those are the spinocerebellar tracts. So they also, the first order neuron ends in the posterior gray horn in the Clark's column or the nucleus dorsalis. And there are two tracks, right? One cross to the opposite side and goes into the anterior spinocerebellar tract. The another one, they ascend in the same side as the posterior spinocerebellar tract. So the posterior spinocerebellar tract has the uncrossed fibers. They carry the information from the same side, while the anterior spinocerebellar tract carries information from the opposite side. Right? So this is how it goes, right? The posterior spinocerebellar tract is uncrossed, and you know that So you see in the previous occasion, the conscious sensation usually go to the opposite side cerebrum. So that is why the posterior column and the spinothalamic tract, they always cross to the opposite side. But you know, the cerebellum controls the same side of the body. So that is why the posterior spinocerebellar tract, so that will be entering the same side cerebellar cortex. And it is through the inferior cerebellar peduncle, which is the connection of the medulla to the cerebellum. So then I will learn that the anterior spinocerebellar tract cross to the opposite side, but as this information is supposed to go to the same side cerebellum, so it cross again. So there is a double crossing so that it will reach the same side cerebellum. And this crossing occurs in the superior cerebellar peduncle in the midbrain. In the lower midbrain, you see that there is a crossing of the superior cerebellar peduncle. So that is where these fibers goes to the particular side of the cerebellum. Right. Yeah, so have this knowledge about this because I have seen in your past papers sometimes you are asked to draw the pathway of the different types of sensation from the receptor to the brain, the cerebrum. So you should know where these sensory fibers lies in which um, sensory tracts. What are the nuclei involved? What are the white matter pathways in the cerebrum where it goes through. So it is better to have some idea about the overall pathway, right? The previous diagrams, they show the different types of receptors where the cell body is, the first order neuron. So generally you can combine both these diagrams and have a comprehensive one diagram to each pathway, right? So that is, I saw that is asked in the past paper question, so you should be able to draw it, right? Or at least outline the pathway using a flow chart, right? Right. So then, yeah. So basically, there are a lot of similarities of these ascending tracts, right? So all these ascending tracts have their first order neuron, the cell body in the posterior root ganglion, right? So if it is for this conscious sensation, the pain, temperature, touch, pressure, proprioception, vibration, right? Always the second order neuron cross to the opposite side. Second order neuron is the one which cross to the opposite side. The crossing might be occurring at different levels, right? For the spinothalamic tracts, it is in the spinal cord. For the posterior column, it is in the lower medulla, right? And these conscious pathways form lemnisci in the brainstem. The spinothalamic tracts form the spinal lemniscus, and the posterior column forms the medial lemniscus. So second order neuron ends in the VPL nucleus of the thalamus. They goes through the posterior limb of the internal capsule, then through the corona radiata into the sensory cortex in the parietal lobe of the cerebrum. So there is the conscious pathway, the common conscious sensory pathway. But if it is unconscious pathway, so that you just have two neurons, there are no three neurons. The second order neuron, right? So they always enters the first order neuron ends in the spinal cord in the Clark's column. The second order neuron is the one which enters the cerebrum through the cerebellar peduncles, right? And they end in the same side cerebellar cortex, right? So these are the common features of the different pathways. Right. So then about the descending tracks, I told you mainly it is about the pyramidal pathways, the lateral and the anterior corticospinal tracts. We are talking about the upper motor neurons and lower motor neurons. The lateral corticospinal tract, so that is a larger one. So it has the fibers which are already crossed. So this crossing occurs at the lowermost part of the medulla in the brainstem. So they are already crossed. So they will be innervating the lower motor neurons of the same side. The anterior corticospinal tract has the uncrossed fibers. So they need to cross to the opposite side at the termination. And they will innervate the lower motor neuron again of the opposite side. Right? So this is what happens. You can see that most of these pyramidal fibers, so they arises from the pyramidal layers of the cerebrum, right? But of course, we have seen that there are some corticospinal fibers which are even arising from the 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 other areas of the, for example, the parietal lobe, right? So there are some fibers which are arising from there as well. So it descends through the corona radiata. The motor neurons does not end in the thalamus. Thalamus is mainly a sensory structure, right? So uh, there are some motor control effects, but generally the motor neurons does not relay. They stop there. So it descends through the midbrain, the pons, and the medulla. And at the lowest part of the medulla, about 90% of the neuron cross to the opposite side, forming the lateral corticospinal tract. So they innervate the lower motor neuron. The uncrossed fibers descend as the anterior corticospinal tract, but at the site where they leaves, so it crosses to the opposite side and innervate the lower motor neuron. So this is the pyramidal pathway, right? But in addition, so we have a lot of extra pyramidal tracts which are arising from different basal nuclei, right? Substantia nigra, right? The red nucleus. Some fibers arising from the vestibular nuclei, so that is concerned with maintaining the posture. Reticular formation, right? So that is a collection, a very diffuse collection of neurons in the brainstem. I'll just mention about it. So these are basically for the involuntary kind of movements and also the regulation of voluntary movements, maintaining the balance, the posture, right? And there are some activities that we can do without thinking. They are voluntary activities, but we can do it without thinking. When you do the cycling, we do not always think that now I have to pedal, I have to push this side and press the other side. We don't do that. Those they are even though they are voluntary movement, they are automatic movements. So it is shown that these extra pyramidal pathways helps that kind of movements as well. Not only involuntary movements, the voluntary automatic movements, even the voluntary skill movement, there is some control from these extra pyramidal pathways, right? And also it helps a lot to maintain the posture, the balance, the adjust the posture to maintain the balance, right? Right. So there is the anatomy, the neuroanatomy of the spinal cord. So we'll go into the clinical effects of these, right? So generally, of course, you do not see the different tracts individually affected except in the posterior column, probably. But generally, it is a combination of the different areas of the different tracts of the spinal cord affected in different clinical conditions. But to work out, you should know what happens when each tract is damaged, right? So you know when the fasciculus gracilis and the fasciculus cuneatus, so that is a posterior column, when it is injured, so as it is carrying the fibers from the same side of the body, right? So so right, so its injury will cause the ipsilateral loss of this sensation, right? So like the discriminative touch, the vibration, the proprioception, so they will be lost in the same side of the body because they have the uncrossed fibers, right? So then about the spinothalamic tracts, and you know the spinothalamic tracts carries information from the opposite side of the body. There is a special thing of this about the spinothalamic tract because they are not crossing, the second order neuron is not crossing at the same level. They are crossing across several or few spinal cord segments. So what happens is when there is a spinal cord lesion, right? At the level of the lesion, of course, the first order neuron and the nuclei will be affected. So there will be the ipsilateral band of sensory loss, the same side. So as the first order neuron and the nuclei are affected, so the affected side, so there will be the band of anesthesia, right? And in the opposite side, right? So so this will, you can see the area which is damaged. So if this is damaged, right? So for example, right, so if the entire region is damaged, so the first order neurons which are here will be affected, and then the spinothalamic tracts. So the spinothalamic tracts, as they cross obliquely, what you can see is the spinothalamic fibers, right? The second order neurons which are rising from the same level or one segment below will not be affected. What will be affected is, what will be affected will be the neurons which are few levels below, right? So that is why in the spinothalamic tract injuries, the loss of sensation in the opposite side occurs few segments below the level of the lesion. So think if the spinal cord lesion is at the T10 level, right? So they will not have the sensory loss below the umbilicus, right? Because umbilicus is T10, right? But the sensory loss will be generally confined to the lower limb. The lower abdomen is T11 and T12. That area will have the normal sensation, but the L1 level below, so they will lose the sensation, right? So there is an important thing about the spinothalamic tracts, right? So then there is another important thing about these tracts, right? In the spinal cord, they have a thing called lamination. So that is because, for example, think about the posterior column. So the posterior column receives sensory information, right? So as the new sensory information is added to the spinal cord, the previously entered fibers, they are pushed to the side. So in case of posterior column, they are shifting towards this side, right? So the sacral things are pushed towards the middle, and the cervical fibers which are entering last will be more towards the lateral aspect. And in case of spinothalamic tract, this is the one which is more important. For clinically, you can see they have the fibers which are crossing and coming from this side. So the sacral fibers are pushed towards the periphery. The sacral fibers are pushed towards the periphery, and the cervical fibers, which enters the spinal cord last, they are towards the center. So this knowledge is important, because if there is the external compression of the spinal cord, so if the spinal cord is compressed from the outside, what will be affected first would be the sacral sensation. But in clinical practice, we see the clinical lesions. You might have heard of syringomyelia, the central cord lesion, where the lesion begins from the center, right? So that type of things are characterized by the sparing of the sacral region. So there is a thing called sacral sparing. So there are upper limbs and the chest area, so that region will be affected. So there will be sensory loss in those regions. But for example, the perianal sensation, the sensation around the buttock, so that area will be spared, right? So that is sacral sparing is seen in this central type of a lesion. The reason is the lamination of these different tracts. So we call this the dissociated sensory loss, right? So it is not the sensory loss which is expected in all the areas, but only certain areas are affected because of the lamination, right? Yeah, so having all these knowledge, right? So yeah, of course, I did mention about the motor pathways, right? So the motor neurons, right? So you saw that there is a upper motor neuron and the lower motor neuron, right? So the effects of the upper motor neuron lesions and the lower motor neuron lesions are different. You have learned this in your clinicals, right? So the upper motor neurons cause spastic type of paralysis with exaggerated reflexes. There will be loss of superficial reflexes, positive Babinski sign, all that. But the lower motor neuron gives rise to the reduced muscle tone, right? So there will be fasciculations, the muscle atrophy will be much serious, right? Looking at the clinical features, that muscle tone, the reflexes, right? So that will give us an idea what kind of a motor neuron lesion is this, right? Right. So having all this knowledge, you should be able to work out the different clinical scenarios affecting the different areas of the spinal cord. But what you need to know is, so in the real clinical practice, in the acute spinal cord injuries, in the initial period, right, you do not see the classical neurological symptoms and signs, because in that period, the patients will be in a condition known as a spinal shock. They are all the motor, all the sensory functions below the level of the lesion, right? So they are lost, right? But later they will appear, right? But you see the classical features in the chronic lesions, but and also in acute lesion, sometime usually after about 1 day, so they develop the real neurological symptoms. So we look at the common things, right? The easiest thing would be the complete cord transection, where the spinal cord is damaged. The complete spinal cord is damaged, so there will be the affected segment, the lower motor neuron will be damaged, right? So that will cause the lower motor neuron type of paralysis. As it is just one segment, it might not be very distinct, but you see the upper motor neuron type of lesion, the spastic paralysis, right? Below the level of the lesion with the loss of all the sensation on both sides, right? And due to the loss of the autonomic fibers, they will have the loss of bladder and bowel control as well, because you know the external urethral sphincter and the external anal sphincter, they are uh, uh, controlled by the spinal cord, as well as there is some autonomic control over the internal sphincter, so all that will be lost, right? Right. So then, what is more frequently asked in questions is the hemisection of the cord, the Brown-Sequard syndrome, where only half of the spinal cord is damaged. We see these in vertebral injuries, the stab injuries, gunshot injuries, different types of spinal cord tumors, right? So, which will cause the characteristic clinical picture. So, there will be a band of anesthesia at the level of the lesion due to the damage to this first order neuron and the cell body there, right? So, then the posterior column sensations are lost below the level of the lesion, right? So, that is because they carry the same side fibers from the same side. So you can see there's a damage to the spinothalamic tract, so that will cause the loss of pain, temperature, touch, pressure, sensation, but it will be few segments below the level of the lesion. So that is a classical feature that you see in the Brown-Sequard syndrome, the hemisection of the spinal cord. Right. Right. So then I told you about the central cord lesion, where so like the syringomyelia, right? So where is a kind of a cavity formation occurs in the center of the spinal cord, which is characterized by the sacral sphere, right? So the sacral region has the least neurological effects, and this is due to the lamination of the spinal cord. Right. So then there are some syndromes which can be explained by the blood supply of the spinal cord. Basically, what you need to know is the spinal cord is supplied by two main arteries. The anterior spinal artery begins from two twigs which are coming from the two vertebral arteries and descends on the anterior median fissure. And then there are two posterior spinal arteries again arising from the vertebral arteries, right? Yeah, sometimes they might be arising from the posterior inferior cerebral arteries as well, but generally they are tributaries of the vertebral artery, right? And at each spinal cord level, there will be some additional arteries which are supporting this arterial supply, right? So that is what you see here. So there will be the segmental arteries which are supplying the spinal cord. So this anterior spinal artery, the single one, it is supplying in the anterior 2/3 of the spinal cord, basically except the posterior column. The rest is supplied by the anterior spinal artery. So if there is occlusion of the anterior spinal artery, it will lead to the loss of all the neurological functions. That means bilateral paralysis, bilateral sensory loss, the pain, temperature, touch, and pressure, except the posterior column sensation, because in anterior spinal artery occlusion, posterior column in both sides, they are not affected. So that is anterior cord syndrome. And here you see that in the posterior spinal artery occlusion, generally it will affect only one side of the spinal cord. So that means same side posterior column sensation would be lost. So if you know what is there in each part of the spinal cord in different gray horns, different white columns, so so you can generally work out what kind of clinical features they could have. For example, so the encephalitis, which is known as tabes dorsalis, so they generally affect the bilateral posterior column, right? Similarly, in Friedreich's ataxia. Then the poliomyelitis usually affect the anterior gray horn only, so they will be limited to the lower motor neuron type of lesions. So if you know what is there in each gray column and each white gray horns and the white columns, so you can generally work out. And if you know what area is affected by each clinical condition, so we can work out what would be the clinical features, right? Yeah, so that is about the spinal cord, right? Right. So then we'll quickly move into the brain stem and we'll I give you a break. Before moving into the rest, yeah, I know I'm just going very, very fast, right? But I hope you have the basic understanding because I used to do last few years, I've been doing the entire neuroanatomy series of lectures for the undergraduates, so which took me about 20 hours, right? So, and I'm trying to summarize everything into 2 hours, right? So it is not an easy job, right? Yeah, so we'll move into the next topic, the brainstem. I'll not spend much time on this. The brainstem has a lot of sensory pathways, motor pathways. It has the areas which are concerned with the consciousness, the alertness, we call it the reticular formation. It receives the sensory and the motor inputs and outputs from most of the cranial nerves except the first and the second, right? And it contains the important autonomic centers, our cardiovascular and the respiratory centers. So it is a very important area in the nervous system, right? And it lies in the posterior cranial fossa, anterior to the cerebellum, right? And we know it is divided into three parts: the midbrain, the pons, and the medulla, right? So there are a lot of cranial nerves, except the first and the second. All the other cranial nerves, they arises from the surface of the brain stem, right? So they are in order, right? So from first to the third to 12th, so they are in a particular order, right? So we'll discuss about that. And there are some important anatomical features, the external anatomical features you are supposed to know, especially that it become relevant when you draw the cross sections. For example, in the anterior brainstem, we have in the upper medulla, we have the in the entire medulla, we see the two central swellings. So those are the two pyramids. And in the upper medulla, we have the two olives and further the two inferior cerebellar peduncles. The pons has a central groove, which is a basilar groove, which is for the basilar artery, right? And in the medulla, in the midbrain, we have two elevations on either side, which we call the cerebral peduncles or the crus cerebri, and the interpeduncular fossa in the center, right? In the posterior aspect, in the upper medulla, we see the gracile and the cuneate tubercles. Those are the areas where you find the gracile and cuneate nuclei. And you see the part of the medulla, upper medulla is behind it, you have the fourth ventricle and also behind the pons. So this upper part of the medulla, we call it the open medulla because it is open posteriorly. So then in the midbrain, so there are four structures. We call this the superior and the inferior colliculi, right? So those are the main external features. And having knowledge about this helps in in drawing a cross section of the brainstem, right? Yeah. So the brainstem, as I told you, it contains a part of the ventricular system. We learned about that. It contains the ascending tracts. It contains the descending tracts. It has the nuclei of the cranial nerves from 3rd to the 12th. Lot of additional nuclei, and generally the substance of the brainstem is filled by the diffuse set of neurons, which are known as the reticular formation. Right. So all these are important. Right. So, and having a knowledge about these would be important when you work out the clinical effects of the different brainstem injuries. Right. Yeah, you know how the ventricular system is arranged. In the midbrain, we have the cerebral aqueduct. In the pons, we have the fourth ventricle, which extends into the upper medulla, and the lower medulla has a central canal. Right. So that is it. Right. So then we have the ascending tracts in the brainstem. They are arranged as lemnisci. So the posterior column fibers continues as the medial lemniscus. The spinothalamic tracts ascend as the spinal lemniscus. Right. So then there is a ascending hearing pathway, which is from the lateral lemniscus. And the sensory fibers from the region of the head and neck mainly comes through the trigeminal nerve. And those fibers also ascends to the cerebral cortex through the brainstem. And in the brainstem, these sensory pathways from the head and neck region, especially the facial region, so that goes through the trigeminal lemniscus. So lemnisci are the collection of sensory neurons that you find in the brainstem. Right. So then the descending tracts, of course, we have the pyramidal pathways, the corticospinal tracts. Additionally, the brainstem has a corticonuclear tracts. Usually both goes together, but the motor fibers, the descending motor fibers which innervate the motor cranial nerve nuclei, those are known as a corticonuclear or the corticobulbar tracts, right? So then we have the extrapyramidal pathways, which are generally coming from the basal nuclei going downwards, right? Additionally, we have the descending autonomic fibers as well. Right? So which is going towards the spinal cord and leaving the spinal cord at the different levels. Yeah, so looking at the cranial nerve nuclei, so the many cranial nerves, so they have the motor nuclei, right? So except the special sensation, so that is the first, second, and the eighth. They are for the special sensation. The first one vision, second one olfaction, the eighth one is for the hearing and balance. So except those, you can see the third, fourth, fifth, sixth, seventh, ninth, 10th, 11th, and 12th. Right? Everything has a motor nuclei and they are in the brainstem. And they are in a particular order. The third and fourth in the midbrain, the fifth and sixth in the fifth, sixth, and seventh in the pons, right? And then 9, 10, 11 in the medulla. Right, so they are in an order, right? So from top to bottom. So then we have the sensory parasympathetic. So there is a motor part. There are 4 cranial nerves which have parasympathetic output. You know, the third nerve, the oculomotor nerve, it supplies the ciliary muscles, right? The constrictor pupillae, right? Dilator pupillae muscle, right? Right. Yeah, constrictor pupillae. It is parasympathetic, right? So it reduces the light. The constrictor pupillae and the ciliary muscles. So that is from the third nerve. Sublingual, submandibular glands are from the facial nerve. Facial nerve also supplies the lacrimal gland, the glands in the nasal cavity, the palate. So all that is from the facial nerve. The parotid gland receives parasympathetic innervation from the glossopharyngeal nerve, and the vagus nerve gives parasympathetic innervation to the cardiorespiratory things as well as the GI tract, right up to the end of the midgut, not to the hindgut. So that means the descending colon, rectum. So those are not supplied by the vagus nerve, but up to the somewhere in the middle of the transverse colon. Right, so those are the cranial nerve parasympathetic one. Then the sensory nuclei are there for the fifth one. Fifth one has a long nucleus with 3 components, right? So that is the mesencephalic, the main sensory and the spinal nucleus. So then there's a common taste. We generally tell it is a common taste nucleus. So that is the nucleus tractus solitaris, which is the common sensory nucleus for the 7th, 9th, and 10th, right? Because those are the cranial nerves which carries the taste sensation. From the tongue, right, anterior 2/3 of the tongue, it is the facial nerve. From the posterior 1/3 of the tongue, it is the glossopharyngeal nerve, and from the pharynx and the palate, it will be the uh, the vagus nerve, right? So that is the common sensory nucleus for these three nerves. And then we have a special sensory nuclei, the combination of sensory nuclei, the vestibulocochlear nuclear complex in the lower pons and the upper medulla. So all these are there in the brain stem, right? So this shows the different arrangement of different cranial nerve nuclei, the motor nuclei in one side and the sensory nuclei in the other side, right? Yeah, so you know where they emerges. All the cranial nerve emerges from the anterior aspect or the anterolateral aspect of the brainstem, except the fourth nerve. The trochlear nerve is the only nerve which emerges from the posterior side of the brainstem, right? Right. So then I told you the substance of the brainstem is filled by the reticular formation, right? So that is a diffuse collection of neurons, but anatomically we tell that there are three columns, right? It is arranged as three columns, but you don't see it really in the anatomical description. But for the descriptive purposes, it is described as three columns, right? And this reticular formation is the main thing which is responsible for maintaining the consciousness, the alertness, right? And also maintaining the circadian rhythms, the autonomic nervous system, right? It has some fibers which are descends into the pain pathway, so it is important in the pain modulation. So that is why the reticular formation is one of the targets of the general anesthesia, right? And also when the reticular formation is damaged, so it will affect the patient's conscious level and the patient will have the sleep disturbances. So these features that we see in brainstem lesions, so that is due to the damage to the reticular formation, right? So that is not a very distinct, anatomically distinct thing, but it is a very important set of neurons in the brainstem. Right, so we'll quickly move into, I told you, I'll just briefly tell you how to draw a cross section with the real knowledge rather than remembering the cross section of the brainstem. So when you draw, when we tell this to the undergraduate, we tell them, right, if you draw a cross section, we'll be looking at the different, the set of things. We'll be giving marks for the different things. So the cross section should have the correct shape. To know the correct shape, you should know the external appearance. You cannot draw a medulla which looks like a midbrain, right? So the medulla is very cylindrical, while the midbrain is somewhat like a short trouser, right? So it has different appearance. So then you should locate the correct part of the ventricular system, whether it is the aqueduct, fourth ventricle, or the central canal. Then locate the descending tracts, especially the pyramidal fibers. Then go on locating the ascending pathways, the different lemnisci. Think what are the different cranial nerves at each level and draw the cranial nerves, right? And then are there any other additional structures? You have to think in this line and draw it systematically so then we don't miss anything. So for example, if you just draw the lowermost level, so that is at the lowest part of the medulla where the crossing of the pyramidal fibers occurs. So the external appearance would be very similar to the spinal cord. It is very cylindrical with the central canal in the center. The anteriormost aspect, you know, they have the pyramids, but in this place, the pyramids are crossing to the opposite side. And you know, the cross fibers goes into the lateral side. So that is why we saw it. So these are the set of fibers which are going to form the lateral corticospinal tract. Right? So that is the descending pathway. So then these ascending pathways we found in the spinal cord has to be there. So we'll have the fasciculus gracilis and cuneatus. The two spinothalamic tracts two spinocerebellar tracts would be at the same location. And the spinothalamic tracts will now unite to form the spinal lemniscus. And at this particular level, you come across the motor nucleus of the vagus and the spinal nucleus of the trigeminal nerve. And by the knowledge of the spinal cord, we know the motor nuclei are anterior to the central canal and the sensory nuclei are posterior. Because in the spinal cord, you know the motor nuclei are here and the sensory nuclei are here. So in the medulla, it is the same. The motor nuclei are anterior, that is the vagus nerve motor nucleus or the accessory nerve, right? So this is the spinal nucleus of the trigeminal nerve. So then you can draw the vagus nerve. So that complete the cross section. Right. So you can do the draw the second section in the same manner, right? So it is again a cylindrical structure, but there you find the four tubercles, right? That is gracile and the cuneate tubercle, and anteriorly you have the pyramids, right? The part of the ventricle would be the central canal. You have the two pyramids at the front, right? So then you go on place in the posterior column. You have the nucleus gracilis and the nucleus cuneatus. So the fibers comes there. The second order neuron begins at that point and cross to the opposite side. So there is a sensory decussation. You have the spinocerebellar tracts and the spinal lemniscus, right? So those are the ascending tracts, So then think about this cranial nerves. You again have the trigeminal nerve nucleus, that is sensory, and the vagus nerve nucleus and the vagus nerve arising from that. So that complete the second section. Right. So then we go into the upper medulla, that is the open medulla, where we have the fourth ventricle at the back, and anteriorly you come across the pyramid, the olive, and the inferior cerebellar peduncle. So it has this appearance of like a moth or a butterfly with the fourth ventricle there. The anterior bulge is the corticospinal fibers or the pyramids. The second bulge, olive, is the inferior olivary nucleus. The third bulge is the inferior cerebellar peduncle. So we have already drawn the descending tract. So locate the ascending tracts. So now this posterior column is forming the two medial lemnisci here. So then we have the spinal lemniscus. The anterior spinocerebellar tract will be there, but the posterior one will not be there, because the posterior spinocerebellar tract enters the inferior cerebellar peduncle and goes into the cerebellum, right? So we don't not draw the posterior spinocerebellar tract there because it is now inside this. Here, the important thing is the cranial nerves, or everything is important, but there are a lot of cranial nerves. So look at these as all set of cranial nerves you will come across there. But here what you need to remember is this is like the spinal cord or the medulla, which is cut and open laterally, right? So the spinal cord is split, or the medulla is split along this midline posteriorly, and it is opened up. So what you find is, right, so the most at the center you find the motor nuclei. The sensory nuclei will be at the periphery because now it is shifted into the sides. So you locate all the motor nuclei in the center, in the medial side, close to the middle, and the sensory nuclei will be at the periphery with some autonomic nuclei in the center. So what are the motor nuclei? So you find the hypoglossal nerve nucleus, right? And the hypoglossal nerve, you know that it comes between the pyramid and the olive, so it will be coming out like this. Then we have the motor nucleus of the vagus, the parasympathetic nucleus of the vagus, and the sensory nucleus of the vagus. So the vagus nerve will be arising from all these nuclei. So these set are motor nuclei. This one is parasympathetic. So the sensory one will be further lateral. So we have the spinal nucleus of the trigeminal nerve and the vestibulocochlear nerve nuclei, right? So they are more lateral. So then, in addition to these regions, so from the level of the vestibulocochlear nuclei above, we have another important structure in this cross section, which we call the medial longitudinal fasciculus. Medial longitudinal fasciculus is a neuronal connection between different cranial nerves. So that basically allows the adjustment of posture, right, and the eyes based on the head movements, right? So you know the head movements, they will be detected by the vestibulocochlear nerve, and to adjust the more eyes with that, so we need that nucleus to be connected to the nerves which are concerned with eye movement. That is the third, fourth, and the sixth nerves: oculomotor, trochlear, and the abductor nerve. So this medial longitudinal fasciculus connects the vestibulocochlear nerve nucleus to those nuclei, as well as it connects it to the accessory nerve, right? So because with the movements of the head and neck, so that is largely done by the sternocleidomastoid and the trapezius. So when you find the vestibulocochlear nerve, so you find in this so from this upper medulla level upward up to the upper midbrain, you find this nerve tract, right? The nerve fiber pathway, which is known as a medial longitudinal fasciculus, which is a set of connecting neurons between different cranial nerves. So that is the upper medulla. This is very important, right? So because that is the generally when you look at the series of past papers, so this is the one which is most commonly asked to draw, because the commonest brainstem strokes, they affect this particular upper medullary region. We call it the lateral medullary syndrome and the medial medullary syndrome, right? So then we go into the pons, which is somewhat like a opened area with the central groove for the basilar artery, and we have the fourth ventricle at the back, right? Here there are a lot of transverse pontine fibers which divide this pyramid. Pyramid sticker, so it is divided into small bundles. So then the ascending tracts, we have the medial lemniscus, the spinal lemniscus, right? And then we have the inferior cerebellar peduncle at the lower level, so you can see, right? And then about the cranial nerves, what you find here, as it is in the somewhere in the middle of the pons, or in the, we call it the facial colliculus. So you can see in the flow of the fourth ventricle, there is a elevation. So this facial colliculus is formed by the fibers of the facial nerve which are going around the abductor nerve nucleus, right? You can see this is the abductor nerve nucleus, and then the nerve fibers of the facial nerve goes around it. It forms a prominence in the surface, so that is how it is arranged. So in addition to that, so in this region you might find the spinal nucleus of the trigeminal nerve, and even some vestibulocochlear nuclei as well, and the medial longitudinal fasciculus. Okay. So then if we go a little bit higher up in the pons, so that is the region where we are going through the trigeminal nerve nucleus. Most of the structures would be similar, but in the place where you find the sensory nerves, so sensory nuclei, they are further lateral. You saw the motor nuclei are towards the center, but the sensory nuclei are towards the periphery. So you find you have the main sensory and the main motor nucleus of the trigeminal nerve. The rest would be more or less the same. Right, so then we go into the next one, the midbrain at the inferior colliculus level. So it appears like, I told you it is like a short trouser. There are two crus cerebri or the cerebral peduncle with the interpeduncular fossa. You have the inferior colliculus here. The crus cerebri is separated from, the way part of the ventricular canal would be the cerebral aqueduct with a lot of gray matter around it. The crus cerebri is separated from the rest of the midbrain by the substantia nigra. That is a type of basal ganglia, which is important for the involuntary movements, right? And then the anterior most part contains the corticospinal and the corticonuclear fibers. So there is a descending pathways. The ascending pathways, you have the medial lemniscus, spinal lemniscus, trigeminal lemniscus, lateral lemniscus, everything, right? All the lemnisci are there now because they are ascending, right, from the towards the cerebrum. And I told you at this level you find the trochlear nerve, right, which is the only cranial nerve which emerge from the posterior aspect, and the only cranial nerve which cross to the opposite side as well, right? So then we have the medial longitudinal fasciculus, and at this level you find the decussation of superior cerebellar peduncle. You saw the superior, I told you, the posterior spinocerebellar tract, they cross to the opposite side through the superior cerebellar peduncle at the midbrain level. So that is what you see there. So the next level, the uppermost level, would be very much similar, except that you do not find the lateral lemniscus there, because this lateral lemniscus is it's a component of the hearing pathway. The fibers of the lateral lemniscus leaves the midbrain by entering the inferior colliculus. So by the time that you come into the superior colliculus, that hearing pathway is not there. That is why I did not draw it there. The rest would be the same, only difference is, so we have the red nucleus, important nucleus there, again kind of a basal nucleus, right? And then we have the oculomotor nerve, which is emerging through the interpeduncular fossa, right? Yeah, so that is the brainstem, the internal structure of the brainstem. So we'll quickly see how we can apply this knowledge to describe the different clinical conditions. But before that, a little bit about the blood supply, because brainstem is involved in strokes, right? So, it is mainly from the posterior circulation. Two vertebral arteries becomes the basilar artery, from the posterior cerebral artery. This system gives rise to the spinal arteries, the anterior and posterior spinal arteries. We learned about that. And it gives rise to three cerebellar arteries: superior, anterior inferior, and posterior inferior. And it gives a lot of pontine branches to the pons. So the different areas of the brainstem are supplied by the adjacent arteries. Most importantly, that is the blood supply of the medulla. The central part is from the vertebrobasilar system, and the lateral aspect of the medulla is from the posterior inferior cerebellar artery. Call it the pica, right? Because that is the artery which is most commonly involved in brainstem strokes. We call it the pica syndrome or the lateral medullary syndrome. Right? So that is, yeah. So that is what you see here. So this is a distribution of the pica, the posterior inferior cerebellar artery, and this side is from the vertebrobasilar system. So if there is a damage to the area which is supplied by the lateral medullary syndrome, so you can see what will be affected. The patient will have the vagus nerve palsy, dysphagia, dysarthria, right? So there will be the sensory loss in the face, right? So that is due to the spinal lemniscus, spinal nucleus of the trigeminal nerve, right? So spinal lemniscus may or may not be affected. If it is affected, it will cause the contralateral loss of pain, loss of sensation. So the sensation in the face will be affected in one side, and the sensation of the body will be affected in the other side. Right? The face sensation is to the spinal nucleus of the trigeminal nerve. The body general sensation, except the vibration proprioception thing, so that is from the spinal lemniscus. They will have damage to the vestibular nerve and the cerebellar peduncle, so that is why they have a lot of cerebellar signs and the vestibular signs, vertigo, nystagmus, right? And also there would be damage to the descending autonomic pathway, so they will have the Horner syndrome. And so is what you see in the lateral medullary syndrome, right? So you might be given a history and ask you to explain how these clinical features occurs in the lateral medullary syndrome. So it is due to the damage or the occlusion of the PICA, posterior inferior cerebellar artery. So medial medullary syndrome affects the central part of the cord. So that is basically contains the pyramid. So that will lead to the contralateral hemiparesis. Medial lemniscus. So that will lead to the contralateral loss of discriminative touch, the proprioception, vibration, those type of thing. And the patient will have the hypoglossal nerve palsy on the same side. Right? So that is what you see in the medial medullary syndrome. In case the pons, in case of the pons, the commonest thing would be the pontine hemorrhages. The clinical features depends on the extent of the lesion. Very commonly, they affect the facial nerve and the abductor nerve, right? So they will have the diplopia, right, in the lateral gaze, right? So because the abductor nerve is gone, the facial paralysis on the same side. So this would be the lower motor neuron type facial paralysis because the nucleus is affected. Contralateral hemiparesis, and the patient would have the Horner syndrome, right? So due to the descending autonomic fibers, so those will be caused by the pontine hemorrhage. But remember, if the hemorrhage is extensive, it might even affect the sensations, right? If this hemorrhage is extensive and goes towards the more laterally, so that will lead to the sensory effects as well. But usually these hemorrhages are from the central pontine branches which affect the middle part. So that is why it is very commonly limited to the motor symptoms, right? But there can be the effect in this again motor cranial nerve lesions and the paralysis, but there can be sensory cranial nerve lesions if it is extensive. Of course, midbrain vascular lesions are less common than the others, but if you know the anatomy, you can explain. For example, this particular condition, the Wedber syndrome, affect the anterior cord, which will lead to the damage to the corticospinal and the corticonuclear fibers, right, as well as the damage the third cranial nerve. So then we have this other condition. There is a Benedict syndrome, which is little bit more posterior, but towards the midline, which will affect the red nucleus, right? So which will lead to the involuntary movements. Again, the third nerve is affected, and there would be the damage to the medial lemniscus as well, leading to contralateral contralateral posterior column sensation lost, right? Right. So that's it, right? It took about some time extra, right? But I hope that would be helpful. So there is a first part of the lecture which is on the spinal cord and the brainstem. I just slightly here and there mentioned about the cranial nerves as well. So we'll take a small break, about 5 minutes. I want to have a sip of water and then we'll move into the next one, which is on the cerebrum, mainly on the cerebrum and its blood supply. Right. Right. Thanks. Right. Shall I start? Yeah. So you can see most everyone is there. Right. So we'll start the second part. So which is mainly I'll be talking about the cerebrum, its blood supply. But towards the end, I'll be talking about the smaller topics like the basal ganglia, the diencephalon, and the cerebrum, the internal cerebellum, the internal capsule, those regions as well. Right. So the first part I'll just go through quickly, right? So you know the cerebrum. So that is not just the cerebral hemispheres. The diencephalon is considered as a part of the cerebrum, which is basically the thalamus and the hypothalamus, right? So cerebral hemispheres, we have two, which is connected by the white column, set of nerve fibers, which is known as a corpus callosum. And we know the brain has a lot of sulci and gyri, right? So which are important to divide the brain into the different lobes, right? So this is how it appears. You see all the sulci and the gyri. So there's a central connection, the corpus callosum there, right? And you can see in the cerebrum, the most of the gray matter, most of it is outside, which is the cerebral cortex. And there is central gray matter area, so that is basically the thalamus and the different basal nuclei. The white matter has different set of fibers. We'll talk about it, right? So these sulci and gyri, mainly the large sulci and gyri, we use them to divide the brain into different lobes, right? Mainly the these lateral sulcus, the Sylvian fissure, and the central sulcus, which we call the Rolandic fissure, and then we have the parieto-occipital sulcus, right? So those will be used to divide the brain into the lobes. So we have the frontal, the parietal, the temporal, and the occipital lobes, right? So that is the basics about the cerebral hemispheres, right? So just skip it. So a lot of pictures. Right. So then looking at the cerebral cortex, so that is where the neurons, the nerve cell bodies of the cerebral cortex lies, right? So they is arranged into, generally it is the typical arrangement is it is tend to have 6 different layers, right? So of these 6 layers, the third and fifth are the pyramidal layers, that is where the motor things are beginning, and the second and fourth are the granular layers. So depending on the function of the cerebral cortex, these different layers have different thickness and the neuron density. And that is how the cortex is arranged to control different functions, right? So depending on the amount of neurons and the neuron density, right, and the type of neuron they will be doing different functions. Yeah, for example, so that I've been telling you that the motor layers, right, the motor areas of the cortex, right, so that is the in those areas we see that the third and the fifth layers are very, very prominent, right? So then in the sensory layers we see the layer 2 and the layer 4 are very well developed. So this neuronal arrangement gives a functional localization of the cerebral cortex, right? So if we look at the different functional areas of the frontal lobe, it has the primary motor cortex, the secondary motor cortex, right? So which is generally the coordinator of the primary area and stores the past experience. So then we have the Broca's area, the motor speech area, and the frontal eye field, which is for the coordinated eye movements. And most anteriorly we have the prefrontal area. So mostly it is for the motor functions, but the prefrontal, the front of the frontal lobe, is for the personality, right, and the behavior of the person, right? So then in the you know that this motor cortex has uh, it is not the different areas of the human body are not proportionately represented in the motor cortex. You know, there is a huge area for the region of the hands as well as the face. So this is known as a motor homunculus, right? Important thing to notice, you can see the lower limbs are not in the lateral aspect of this cortex. It is towards the medial side, right? It is like the this person is putting his lower limb into the gutter, right? So that is the lower limbs are in the medial aspect of the cortex, right? So then, so if there is a patient who is has a damage to the frontal lobe, what they will have is they will have the contralateral paralysis, right? And they will have some kind of these for the performance of the skilled voluntary movements. You need some past experience, so these type of skilled movements will be affected very much, right? And there will be the the patient will lose the ability to speak, the expressive aphasia, right? So there is a loss of coordinated eye movements due to the damage to the frontal eye field and a lot of personality and the behavioral changes. So that occurs in the frontal lobe lesions, which has been observed in this typical case of the person who had iron bar going through the frontal lobe. Uh, you can so that is a historical case which gives us the knowledge about the effect of the frontal lobe injury on the personality of the person, right? Yeah, so then about the parietal lobe, so the areas would be the primary sensory area and the somatic association area. The association area, what it do is it takes up all the different sensory inputs and it has kind of an integrative function. For example, if we ask a patient to close the eyes, put a coin in the hand, and ask the patient to identify it, right? He'll be using different sensations. He'll be using the touch sensation, right? The temperature of the coin, and using all these information and the past experiences, the patient would be able to tell that it is a coin. So that function is known as a stereognosis, right? So that is the main function of this association area, right? So then we have the sorry, yeah, the if so what happens, one of the main features that we see in the parietal lobe lesion is this astereognosis. They will lose that ability to identify objects, as well as it will lead to the opposite side sensory loss, general sensory loss. And the sensory cortex has the same homunculus, right? So similar type of homunculus where there is a lot of area which is given to the facial sensation, right? Right, so the temporal lobe, it has the auditory areas, the primary and the secondary auditory areas. It has a Wernicke's area, that is the area which helps us to understand the language, right? And it towards the lateral sulcus, the terminal end of the lateral sulcus, there is an area which is the angular gyrus, which is for the more language function like reading, writing and reading. So that is basically concerned by with the angular gyrus, right? So if there is a damage to these areas, yeah, right. And also what I did not mention is this temporal lobe is considered the most important area for the long term and the short term memory. Right? So if a patient has a temporal lobe lesion, they will have the partial deafness of the ears, right? And they will have the problems in understanding the language, the receptive aphasia, right? They will have problems in reading and writing, alexia, agraphia. There will be memory impairment, right? And if the those language functions are basically affected if the dominant hemisphere is affected. So if we are using right hand, you know our dominant hemisphere would be the left lobe, left cerebral hemisphere, right? So the language functions are done by the dominant hemisphere, and kind of aesthetic functions are done by the non-dominant hemisphere. So like recognition of faces, recognition of music, so that type of things, they will be done by the non-dominant hemisphere. So the temporal lobe lesion, the clinical features depends whether the patient's dominant hemisphere or the non-dominant hemisphere is affected, right? So so that is where this thing about cerebral dominance comes in, right? So because the concept of cerebral dominance comes in because there are certain neurological functions which are carried out mostly by one hemisphere, not by the other. So that is why. So generally we tell the dominant hemisphere controls the things like handedness, the speech, language functions, while the non-dominant hemisphere affect the recognition of the space, right? So, and recognition of faces, the music, right? So that kind of thing. So depending on the hemisphere which is affected, so they will have different features, right? So if if the dominant hemisphere is affected, they will basically have language issues, right? So they will have the aphasia, receptive or expressive aphasia. They will have the problems in reading, writing, doing calculations, right? The alexia, agraphia, acalculia. So all those are kind of a mathematical and language function. So they will be affected if the non-dominant hemisphere is affected. But if the dominant hemisphere is affected, if the non-dominant hemisphere is affected, so that is mainly about the recognition of the space, right? So you can see. So these are interesting cases. Sometimes you see that they ignore one whole half of the world, right? So if we ask to draw a clock, they will draw one side. And in extreme cases, they might even neglect the personal hygiene of one side of the body, right? So you can see this person has only one part of the plate. The other side is ignored. So this is known as hemispatial neglect, which is a feature of the damage to the non-dominant hemisphere, right? Yeah, so that is about the cerebral dominance. So then coming into the last lobe, the occipital lobe, it is mainly concerned with the vision, the visual areas, right? The primary and secondary visual areas should be there, right? But what you need to remember is that the I think there is a vascular lesion of the occipital lobe, and these visual areas has a blood supply from two sources, right? So it is mainly from the posterior cerebral artery, but the central part, the macular vision, so it is from the middle cerebral artery, right? So if only the posterior cerebral artery is affected, usually this macular area will be not affected. So we called it the macular sparing. So it generally affect the opposite side of the vision, right? So if there is a large damage, right, of the entire visual cortex, so of course there will be the contralateral homonymous hemianopia. The opposite side visual loss in both sides, both eyes. But if it is just one artery, the posterior cerebral artery which is affected, the macular region will be spared. And because so it is supplied, it is getting the blood supply from both. ඒ කියන්නේ එක ආටරි එකක් බ්ලොක් වුණාට macular එකේ vision එක නැති වෙන්නේ නැහැ. So we call this the macular sparing, right? Right. So then, of course, there are some other cortical areas somewhere deep in the lateral fissure. We have the insula, which is the taste area concerned with the taste. So then we have the uncus. So that is the anterior bend of the superior temporal gyrus here, right? So that is the uncus. So that is we tell that is the primary olfactory area, and that is clinically important because that is one of the first structures to herniate if there is an increase in intracranial pressure. We call it the uncal herniation, right? So just have an idea about these different areas because they have some important functions. Right. So then looking at the internal structures, right? So that is basically the white matter of the cerebrum. So it has different types of neurons. So there are commissural fibers which connect the two cerebral hemispheres together, mainly the corpus callosum, but we have the anterior and posterior commissures as well. So then there are projection fibers which are going from the cerebral cortex to the lower down. So the internal capsule, the corona radiata, so those have the projection fibers. So then there are association fibers which are connecting the different cortical areas of the same hemisphere together. So we call them the association fibers. So look at the common examples. The commissural fibers, the largest one would be the corpus callosum. So it connects the two cerebral hemispheres together. But additionally, we have an anterior commissure and a posterior commissure. So which connect the two hemispheres. So they sense the information from one hemisphere to another. So the association fibers, the one of the very clinically important thing is these arcuate fasciculars which connect the Wernicke's areas or the Broca's area. For example, when we listen to a question and give the answer, we need the understanding and the expression, both, right? So the Wernicke's area helps us to understand the question, and then that information will be sent into the Broca's area, which will generate the answer, right? And it will be sent into the primary motor cortex to the laryngeal muscles, the tongue muscles, and it will express the real word, right? So that is a typical example of an association fiber. So then we have the projection fibers, mainly the internal capsule and the corona radiata. Of that, the internal capsule will be very important, right? So you know it is trapped between the thalamus and the basal nuclei, the caudate nucleus at the front and the lentiform nucleus in the sides. So it is a wedge-shaped structure with the anterior limb, the genu, and a posterior limb. And it is good to have an idea about what are the things which are carried in each area. Especially, you need to remember the genu is the area which carries the corticonuclear fibers. The motor, so if there is a damage to the genu, it will affect the motor cranial nerves, right? The posterior limb is basically the spinal sensations and the motor functions are carried in the posterior limb. The anterior limb carries the fibers towards the frontal lobe. And more posteriorly, arising from the internal capsule would be the optic radiation, which is going towards the optic cortex, and the auditory radiation, which is going towards the temporal cortex. Right? So this shows the different relations, different parts, and the components of the internal capsule. Right? So that is one of the main parts of the main component of the projection fibers, right? Right. So there was a question. I'll answer it as it goes on. So that is more right. There is more about the cranial nerves. So I'll come into that, right? Right. So I'm talking about the cerebral white matter, right? So what the different types of fibers. So the internal capsule strokes. So they generally so internal capsule is generally supplied by the most of the blood supply comes from the small arteries of the middle cerebral, small branches of the middle cerebral artery, and it is affected by small infarcts, the lacuna infarcts, right? And the effect will depend on the area of the internal capsule that is affected, because you learn that the anterior limb, the genu, and the posterior limb has different types of information. But usually you can see the internal capsule is a very condensed area of neural fiber tracts. So if the internal capsule damage can cause a very widespread neurological injuries, both motor and the sensory functions, right? So the knowledge about the structure and the contents of the different parts of the internal capsule become important, because depending on the area affected. For example, you see here, this patient has a infarct of the posterior limb of the internal capsule, right? So the patient have basically the motor effects, right? The right upper limb, right? So and also this says that this is a real case which shows that the patient has some dysarthria as well. That means there is some cranial nerve motor nuclei are also affected, because it is very close to the genu as well, right? So it depends on the area which is affected, right? So And of course, the within the cerebrum, we have the set of basal nuclei, right? So we have the large caudate nucleus. So that is this bluish color thing, which has a head, right, a body and a tail, which ends in the amygdaloid nucleus. The amygdaloid nucleus is, so usually the basal nuclei are for the involuntary kind of movements, right? But the amygdaloid nucleus, the main function is not the movement, it is more towards the emotions. So because it is considered as a part of the different system, which is known as a limbic system, right? So so that is the about the amygdaloid nucleus. So then we have the lentiform nucleus, which has different parts, the putamen, the globus pallidus, right? So these are very important because in diseases like Parkinsonism, so these are movement disorders. So the basal nuclei are the things that are usually affected because they are concerned with the involuntary movements, right? So the damage to these areas will lead to the movement disorders, right? Parkinsonism, right? Right. So then I told you about the limbic system, right? So that is that has so many different structures involved, like the cingulate gyrus, right? There is contribution from the thalamus, hypothalamus, right, hippocampus, and the amygdala, right? So basically, we remember it as it is involved in 5 F's: feeding, the forgetting, fighting, family, and fornicating. So that means so it is about the hunger and the satiety, the memory, the emotions, right? The sexual functions, sexually arousal, right? The maternal bonding, so that type of thing. So that is controlled by the limbic system, right? So there is not a separate system as such. It is a it is a connection of different neurological areas, so which basically affect the emotional part, right? So So generally, that is how we tell it. The limbic system is for the emotions. So because it is the responding to the different emotional situations, right? Right. So then coming into the clinical part of it, so we need some knowledge about the blood supply of the brain, which is from two main arteries, the internal carotid and the vertebrobasilar system. The internal carotid artery, so you know it is beginning from the common carotid artery at the C3, C4 level. It does not have any branches outside the cranium, right? So in the cervical part, then it goes through the petrous temporal bone, enters the cavernous sinus. After coming out of the cavernous sinus, it divides into its branches, right? So there are the ophthalmic arteries, mainly the anterior and the middle cerebral arteries. So it has some small branches within the cavernous sinus as well. And also this middle cerebral artery, it divides into the anterior superior division and the inferior division. The superior division is going towards the frontal and the parietal lobes, while the inferior division goes towards the temporal lobe, right? So these are the different branches, right? The vertebral artery, you know, it arises from the subclavian artery, goes through the transverse foramina, except the C7 transverse foramina, goes through the foramen magnum, comes into the uh, subarachnoid space in the cranium. The two vertebral arteries joins to form the basilar artery. So we learned about the vertebrobasilar system, its branches, right? So it is basically for the brainstem and the cerebellum, but it also supplies the area of the cerebrum as well. So you should know what are the areas supplied. So then you know that these two systems, they work, they joins in a arterial circle by two communicating arteries, the anterior communicating artery between the two anterior cerebral and the posterior communicating artery between the internal carotid and the posterior cerebral. And we call that the circle of Willis. And I have seen that you have been asked to draw the circle of Willis. So just practice drawing it, right? How the circle of Willis. So this kind of a line diagram would be enough, right? How it is formed. right? You might not, if you are just asked to draw the circle of Willis only, you might not need to draw all the branches of the vertebrobacillar system. So because what is expected is the arrangement of the circle of Willis. But if you have time, no harm in drawing this as well, right? But basically this is very important. You should be able to draw this, right? You don't need to draw a very artistic or a realistic kind of a diagram like this. The line diagram which appears something like this would be more than enough, right? Right, so then you should know what are the areas supplied by the three main cerebral arteries, the anterior, middle, and the posterior cerebral arteries, right? So you can see the areas. So you should be able to draw a diagram of the lateral and the medial aspects of the cerebrum and demarcate, show what areas are supplied by each of these arteries. Because this is very important because these areas are affected in different strokes. The strokes, so they can be either hemorrhagic or ischemic stroke and affect different arteries. So there can be the anterior cerebral artery stroke, middle cerebral artery stroke, or the posterior cerebral artery stroke, right? So we'll look at each of them, right? And then, so looking at the middle cerebral artery stroke, so that is the area which is affected, right? So that is the area supplied by the middle cerebral artery. So you can work out what are the areas. So it will affect the primary motor cortex. So there will be the contralateral hemiparesis, primary sensory cortex. So there would be the sensory loss, contralateral sensory loss. It will affect both the Broca's and the Wernicke's area, which is, so not shown here. So they will have the global aphasia. Both the sensory and the motor part of the aphasia will be affected, right? Right. So I'll answer the next question, right? So then they have the contralateral homonymous hemianopia. So this is not due to the effect of the cerebral cortex because within the parietal lobe, right? So inside the substance of the parietal lobe, we have the optic radiation. So when anywhere damage anywhere beyond the optic chiasma, so that will lead to the contralateral homonymous hemianopia. So this is not due to a damage to a cortical region. So there is a question. In the chat box, so it says a patient presented with weakness of arm and leg and face with hemianopia and dysphonia or dysphasia. I think these are the questions they might have remembered. So they're asking what is the artery affected. The question is not clear. So there are a few arteries mentioned: the superior branch of middle cerebral artery, inferior branch of middle cerebral artery, the sphenoidal branch of middle cerebral artery, lenticular arteries, and the clinoid branch of internal carotid artery. Yeah, so this is I saw these the some of the questions as an issue because what you need to understand is if there's a middle cerebral artery occlusion, generally the lower limbs are not affected because the lower limbs are supplied by the areas of the cortex which are supplying the lower limb are supplied by the anterior cerebral artery. I don't know whether the people have remembered it in a wrong way and written it in a wrong way. So generally in middle cerebral artery, whatever the branch is involved, it does not affect the lower limbs, right? So depending on these features, so they say the patient has weakness of the arm. We'll forget about the leg and the face. The arm and the face with hemianopia and dysphonia. So the dysphasia, I'm not sure. So there is some language, the expressive part of the language is lost. So that means there is a damage to the, so you can work out. So if it is weakness of the leg and the arm, it would be this area. So there is expression of the language which is affected here. And it is telling that there is some hemianopia as well, right? So probably somewhere in the parietal lobe is affected. The rest of the things are not given. So basically where this does not say anything about the language functions, the hearing and the memory part of it, right? So we cannot so it is unlikely to be the inferior branch of the middle cerebral artery. It will very likely to be the superior branch of the middle cerebral artery, right? The sphenoidal branch, the lenticular arteries, the clinoid branches, so those are small branches of the middle cerebral arteries that they will not give rise to this kind of extensive neurological damage, right? Even the lenticular arteries will be supplying the internal capsule, and that will not give rise to much of that will not cause the problems in the language functions, right? Lenticular arteries, if the several lenticular arteries are affected, it will give rise to widespread motor effect, but it will not affect the language functions, right? So we can exclude it. Clinoid branches are not very much important in supplying the cerebral cortex as such. The sphenoidal branches are the same, right? So they do not have much effect. So the main two branches are the superior and inferior branch, but depending on the clinical history which is given in this question, so it is mainly about the weakness of the arm and the face. I just forgot about the leg because the leg will not be affected by the middle cerebral artery occlusion usually. Right? So there can be the little bit extension into that area as well. And this causes some expressive language defects. So this is very likely to be the superior branch of the middle cerebral artery, right? So so that would be the answer to your question.
A small doubt regarding that.
Yeah.
There is a hemianopia as well.
Yes.
Isn't the inferior branch related with the hemianopia?
No, generally the optic radiation we tell it goes it is somewhere deep within the parietal lobe, right? The inferior branch is mainly supplying the upper part of the temporal lobe, right? So when we talk about the optic radiation, so it is that region is mainly from the superior branch, right? Not from the inferior branch.
Thank you, sir.
Right. Okay. Because it is somewhere here, so deep within the parietal lobe. Right? Right. So that is about the middle cerebral artery stroke. Right. Right. So yeah, this again summarizes the same thing. What you see: the frontal eye field, optic radiation, the Broca's area, Wernicke's areas, all that. Right. So if there's an anterior cerebral artery stroke, so what we basically see is you see both motor and sensory defects affecting the lower limb. Because you learn the sensory and motor homunculus, the lower limbs are inside. So they are higher up and they are in the medial aspect of the cerebral cortex. So there is a neurological damage, both motor and sensory effect affecting the lower limbs. And it affects the prefrontal cortex, so there will be a lot of personality changes. And we have what have been observed is this patient has some uh, urinary problems, incontinence, because the continence is controlled by the anterior most part of the frontal lobe. So we have the micturition center. This is something that you might not have heard much. So there is a thing called micturition center in the cerebral cortex, which controls the continence. So which is in the anterior most part of the frontal lobe. So that is why in anterior cerebral artery strokes we see urinary incontinence as a common feature, right? So of course, if the sometimes, right? So you see that they have these the emotional changes. So there may be so this area, the cingulate gyrus, the amygdala. So those areas are concerned with the emotions, right? So they will be also affected. So there will be some emotional things as well, right? So like abulia, right? So all these things, right? So right. So this don't get confused, right? So the anterior cerebral artery occlusions can also affect some language functions as well. But basically, if a patient has a global aphasia, we tell it is a middle cerebral artery. But there are a lot of subcortical structures, right? So a lot of connections between these language areas which are supplied by the anterior cerebral artery. So that will cause some problems in the language functions as well, right? But there you can keep that in the back of your mind. That is not described as a typical feature. Typically, it is the effect in the lower limb, right, with some personality issues, right? Yeah, posterior cerebral artery stroke is mainly about the visual problems, right? So because it is, but also you know that it is supplying the lower part of the temporal lobe in the medial aspect, and the majority of the temporal lobe is from the posterior cerebral artery, so it affects the memory functions as well. So they will have the amnesia, right? And other thing, important thing is the posterior cerebral artery is the main supply to the thalamus as well, right? So yeah, sorry about there's a mistake. So usually in the thalamic infarct, you see a lot of sensory impairment, not much of a motor effect. So in the posterior cerebral artery stroke, you will see that the patients, in addition to these visual effects, right? So they will have the sensory effects as well, right? So that sensory effect, sensory damage, sensory loss is not due to the cortical damage, but it is due to the damage to the thalamus, right? So in the yeah, when I send the lecture note, I'll affect it. So it is mainly affecting the contralateral sensory functions, not much of an effect on the motor functions, right? So because the posterior cerebral artery deep down, it supplies the thalamus, right? Right. So then coming into the last bit, nothing much about the venous drainage, right? So I just, for the completeness, I just included this slide. So they are drained by the cerebral veins, which goes into the intracranial venous sinuses. So which lies between the two layers of the dura. The dura splits into the meningeal layer and periosteal layer or endosteal layer. And in between these dural layers, we have the intracranial venous sinuses. So that is where the cerebral veins usually drains in, right? So, so the cerebral hemispheres and the two cerebral hemispheres, they are separated by the dural fold, the falx, and the cerebrum is separated from the cerebellum from the tentorium, right? So this is just for the completeness. So we have different cerebral venous sinuses. Of all that, the most important would be the cavernous sinus, right? Because there are a lot of cranial nerves which are related to it. We have four cranial nerves, right? Third, fourth, 5-1, that is ophthalmic, and the 5-2, the maxillary nerves in the lateral wall of the cavernous sinus. And within the cavernous sinus, we have the abducens nerve and the internal carotid artery. So if there's a cavernous sinus thrombosis or internal carotid artery aneurysm within the cavernous sinus, it can have a widespread cranial nerve damage, right? So they will have the damage to they will have the problems in the all the eye movements will be affected because the third, fourth, and sixth nerves are there. So they will have the sensory loss affecting the face except the mandibular region because that is ophthalmic nerve and the maxillary nerve. They will have the venous congestion in the orbit, right? So this kind of a clinical picture because the ophthalmic veins are draining into the cavernous sinus. So those veins cannot drain the venous blood. So there is a venous congestion within the eyes, right? So they will have all these clinical features. So if we see these together, so that is the cavernous sinus syndrome, right? Right. Yeah, so then about the diencephalon, basically it is the thalamus and the hypothalamus. The thalamus is a collection of a lot of nerve cell bodies, right? So these nerve cell bodies, they are known as nuclei. So thalamus is a collection of different nuclei. We learned about few of them. I mentioned about the VPL nucleus, right? So, so that is the thalamus is considered as a central sensory nucleus. It receives all the sensory inputs except the olfaction. Of course, there are some olfactory information coming indirectly to the thalamus, but the thalamus is not directly receiving any olfactory inputs. But all the other sensory inputs, both special and the special sensory inputs, they comes into the thalamus. And that is important for the recognition of crude sensory information. That means if there is a middle cerebral artery occlusion with the damage to the sensory cortex, still the patient will be able to appreciate that there is some sensory inputs coming in, right? මොකක් හරි තියෙනවා කියලා දැනෙනවා, but he will not be able to tell the exact place, the exact intensity of the stimulus, right? So so the general recognition of the sensory inputs can be still done by the thalamus, even in the absence of the functions of the sensory cortex, right? So it can recognize, right, but it cannot really appreciate or interpret the sensory information, right? So of course, even though the motor fibers are not stopping in the thalamus, it has some inputs to the motor pathways as well, because it influences the basal nuclei, the cerebellum, so all that, right? And we learn it has some contribution to the limbic system, so it affects the emotions, the memory, so all that functions are there in the thalamus, right? So I just added a chart here. So it has different nuclei. I have not seen that you have been asked questions on the specific functions of each nuclei, but you can see that it has these are the things that I mentioned. So it has ventral posterolateral nucleus, right? The ventral posteromedial nucleus, right? VPL nucleus is for the general sensations of the body. VPM nucleus is the general sensation of the face, right? We have then, the medial geniculate body. So that is this one. So that is for the auditory pathway, the hearing. The lateral geniculate body is for the visual pathway, right? So then, so it has so many things. So for example, this Papa circuit, the anterior part, so that is for the emotion. So that is part of the limbic system, right? It is concerned with, so you can see the different connections of it. It has connections with the basal ganglia, the limbic system, the cortex, right? The auditory pathway, the visual pathway, right? Both motor and the sensory cortex. So it has so many different connections, right? So that is about the thalamus. The hypothalamus is hanging down from the thalamus, and it is the central controlling body of the autonomic nervous system and the endocrine system, right? Because you know the hypothalamus affect the pituitary, and the pituitary secrete all the releasing and the inhibitory hormones to most of the endocrine gland, the adrenal gland, thyroid gland, the gonads. So they are controlled by the pituitary and indirectly by the hypothalamus. And it is part of the limbic system, so it has some functions to do with the emotions. And all the inputs about the satiety, thirsty, the circadian rhythm, they comes into the hypothalamus, and that is how it affects the autonomic nervous system, right? So it receives input from all these areas concerned with the taste, right? The satiety, hunger, right? The day and night changes. So that is concerned with most of these functions are concerned with the limbic system, right? Yeah. So you can see all these different inputs that the hypothalamus receives from the limbic system, the brainstem, the gustatory cortex, right? So the cerebral cortex, even the eye, right? The day and night is recognized by the hypothalamus, and it sends inputs to the thalamus, the autonomic nervous system, the pituitary gland, and also it sends information back into the cortex as well, right? So it has so many different afferent and the efferent connections. Yeah, finally about the cerebellum, right? So cerebellum, the anatomy of it, so basically it is divided into anterior and the posterior lobe, and then it has this, the posterolateral or the flocculonodular lobe, right? So, and it has a central part which is known as the vermis as well, right? So, like in the cerebrum, we don't really talk about the functional demarcation of the cerebrum, but these different areas have different functions, right? So, theoretically, it has been shown. For example, this central region, right? So that is the vermis. So that is basically about the balance and the eye. So that is the central part of the cerebrum controls the trunk, the body axis. So that is about the body balance, basically the vestibular functions, right? So the balance and the eye movements, right? So then we have the other area. So it is, the cerebellum controls the posture, right? So that is from the central vermis part, the paravermis part, right? So that is for the control, but so that gives some regulation for the skilled movements, the coordination. You do this when you do the cerebellar assessment, right? And the lateral part is basically about the planning activities, right? So we call it the motor planning, right? So that is done by the outer part, which we call the neocerebellum. The central part is the spinocerebellum. The lateral part is the neocerebellum. So that is basic, but this is not a very clear demarcation as in the cerebral cortex. But basically, the cerebellum is involved in the motor coordination, maintaining the balance and posture, but it has some function in the motor planning, right? Learning motor skills as well, right? So that helps the execution of these movements in the second and the repeated attempts, right? Yeah, so that is why when the cerebellum is affected, you have a lot of balance problems, the ataxia, dysmetria, right? So you know, then you do the finger nose test, there will be the overshooting or undershooting, right? So then the coordinated movements, right? So it will be affected. So they will have the dysdiadochokinesia, they will have the tremors, dysarthria, right? And also some problems in the eye movement, they get the nystagmus. So all this happens when the cerebellum is affected, right? So that is all for the different neurological things, right? Yeah, I will not be able to go through all the cranial nerves. I'll just skip through, right? I'll just take about 10 minutes and just show what is there in that lecture note. I'll share the lecture note because all the facts would be there. There was a question earlier, right? So this is a patient presented with history of trauma and found to have fracture at the jugular foramen. His swallowing and gag reflex are impaired. What is the nerve affected? Right. Right. So what you need to know is the jugular foramen. Jugular foramen is a common exit point for three cranial nerves: the glossopharyngeal, vagus, and the accessory nerves. Right. The hypoglossal nerve goes to a different foramen. So this patient has a fracture at the jugular foramen. So that it is likely to affect three nerves: the glossopharyngeal, vagus, and the accessory nerves. Right. Uh, so this similar clinical picture can occur in a clinical case which is known as a jugular bulb tumor. So there is a tumor developing in the jugular bulb, or so there is the origin of the internal jugular vein. So which affect the three cranial nerves together, the 9th, 10th, and the 11th, right? So because of the for the internal jugular vein, the 9th, 10th, and 11th cranial nerve, they go south together through the jugular foramen. So we can just exclude the hypoglossal nerve and the facial nerve here, and we are left with the glossopharyngeal nerve and the vagus nerve. So this does not tell anything about the, yeah. So the answers, I'll read the question. This says the patient presented with history of trauma and found to have fracture at the jugular foramen area, right? His swallowing and gag reflex are impaired, right? What is the nerve affected? So we can just exclude the answer වල තියෙන්නේ glossopharyngeal nerve, hypoglossal nerve, trigeminal nerve, vagus nerve, and the facial nerve. So this does not have anything to do with the hypoglossal nerve because it is about the tongue. The movement of the tongue, there is nothing written about that here. Trigeminal nerve. So this has nothing to do with the trigeminal nerve. Trigeminal nerve is nowhere near, right? So it is somewhere higher up and affect the sensory and the motor functions of the face. The facial nerve is also somewhere higher up, right? So it is not there. Right, so what we are left is the glossopharyngeal nerve and the vagus nerve. And of course, the gag reflex, they say the gag reflex is impaired. The sensory part of the gag reflex is from the glossopharyngeal nerve, because the pharynx receives sensory input from the glossopharyngeal nerve, and the motor part is from the vagus nerve, right? So still from the gag reflex, we cannot exclude anything, right? But this says the patient has difficulty in swallowing. Of course, so the pharynx, the main motor supply to the pharynx would be the vagus nerve. Of course, the glossopharyngeal nerve supplies the stylopharyngeus muscle, which is an elevator of the pharynx, which is helps to swallow. But we have other elevators, right, of the pharynx, like the palatopharyngeus, salpingopharyngeus, right? Especially the palatopharyngeus is a very strong elevator of the pharynx, right? So depending on the clinical case, right? So the patient is having swallowing difficulty with the loss of the gag reflex, right? So the best response would be the vagus nerve, right? So glossopharyngeal nerve injuries. So of course in a jugular foramen fracture, the vagus nerve will not be isolated, but you are supposed to find the best answer. So the best answer in this case would be the vagus nerve. Because glossopharyngeal nerve damage, so of course gag reflex will be affected, but it will not cause much of a dysphagia. ගිලින්න ලොකු අමාරුවක් එන්නේ නැහැ. Because the vagus nerve is intact, which supplies most of the muscles of the pharynx. Right? Right. I think that answers the question. So the best response would be the vagus nerve. Right. As I still find a lot of the others, I'll just go through. I'll just show what is there in that lecture note in the cranial nerves, right? And I'll share it with you so you can have an idea, because I have mentioned all this because there are some places where the cranial nerves are affected together. One is the cavernous sinus. One is the CP angle, or we call them the acoustic neuromas or the CP angle tumors, where there is a combination of clinical cranial nerves affected. So that include the vestibulocochlear nerve and the facial nerve, and sometimes the trigeminal nerve. Other one is this jugular bulb tumors or the jugular foramen, where there are several cranial nerves going together. Right? Yeah, I'll just take a few minutes, not much, right? So I'll just finish it off quickly. Somebody is trying to talk. If you want to ask questions, you can put it in the chat box, right? Yeah, so what I wanted to show you is the cranial nerves. So I'll just skip these. So you should know what are the sensory nerves, what are the motor and the mixed nerves, right? And you have already learned where the cranial nerve nuclei located, right? And yeah, I'll just skip this. I'll just focus on the important clinical areas, right? So all the information is there, and you should know where each cranial nerve lives. So that is where it becomes important, because there are cranial nerves going out of the skull together. For example, the superior orbital fissure has all the cranial nerves supplying the orbital structures. Oculomotor, trochlear, and the abducens nerve, and the ophthalmic nerve all goes together, right? So then the jugular foramen, you can see the glossopharyngeal, vagus, and the accessory nerves. Other thing is the internal acoustic meatus, which have the facial nerve and the vestibulocochlear nerve going together, right? So those are important because the damage in these areas will lead to the multiple cranial nerve injuries, right? Right. Yeah, so there is a distribution. So the cranial nerves are basically concerned with supplying the head and neck region. So in the head and neck region, we have different set of muscles. The muscles of facial expression are from the facial nerve. The muscles of mastication is from the mandibular nerve, the third part of the trigeminal nerve. External eye muscles are from the third, fourth, and sixth nerve. The palate, pharynx, and larynx is from the vagus nerve with some contribution from the cranial part of the accessory nerve. The tongue is the hypoglossal nerve. Sternocleidomastoid and trapezius is from the accessory nerve. Other small muscles of the neck are supplied by the cervical plexus, not from the cranial nerve. So then we have the sensation, the special sensation. First one is olfaction. The second one is optic. Third one is, hearing and equilibrium is from the vestibulocochlear nerve, right? So then the taste is from the 7th, 9th, and the 10th nerves. The general sensation of the face is from the trigeminal nerve, and from the internal organs is basically from the 9th and the 10th nerve. Then we have the parasympathetic part, the parotid from the glossopharyngeal, submandibular and sublingual from the facial, and the lacrimal gland from the facial again. We have a lot of small glands in the nasal cavity and the palate, which is again from the facial nerve. Then we have the constrictor pupillae and the ciliary muscles of the eye through the oculomotor nerve. So that is generally summarizes the entire innervation of the head and neck region. ඔය ටික තමයි තියෙන්නේ head and neck region එකේ, and they are supplied by the cranial nerves. So how I used to do it for the undergraduates is I divided it into 4 sessions. One is the nerves of special senses. One is the nerves of eye movement. The other one is for the nerves of the face. And finally, the lower cranial nerves. So I just did it like that. The olfactory nerve, I did not go into detail. So the olfactory nerve is likely to be affected in the anterior cranial fossa fractures, right? So where the patient will have the CSF rhinorrhea, right? Or it might be affected by the frontal lobe tumors. So how they present with is the anosmia, right? So the optic nerve is important. So because you should know what happens to when the different components of the optic pathway is damaged, right? So we have the monocular blindness when the optic nerve is damaged. Very commonly what is asked is, if the side of the optic nerve, optic chiasma is affected, so that will lead to the nasal hemianopia. What is most commonly asked in undergraduates as well as in postgraduate is the bitemporal hemianopia, which is caused by the central optic chiasma lesion. And anywhere beyond the optic chiasma, it will lead to the contralateral homonymous hemianopia, right? So this is the commonest thing, the bitemporal hemianopia in the compression of the central part of the optic chiasma by a pituitary tumor. So they will have the bitemporal hemianopia, right? Yeah, so then the other main only sensory nerve is the vestibulocochlear nerve, which has 2 components, the vestibular and the cochlear component, right? The nerve comes out through the internal acoustic meatus with the facial nerve, right? So that is why when there is a acoustic neuroma, or we call this a CP angle tumor, there will be a damage to the vestibular nerve, vestibulocochlear nerve, and the facial nerve together. So they will have the hearing and balance problems along with the facial paralysis, right? Yeah, cochlear nerve. So just have an idea about the auditory pathway. So it comes from the auditory cochlear nuclei to the superior olivary nucleus, inferior colliculus of the midbrain, to the medial geniculate body of the thalamus, then to the primary auditory cortex, right? So that is the auditory pathway. Vestibular pathway. So the vestibular nuclei has so many connections. I told you, through the medial longitudinal fasciculus, it is connected to all the cranial nerves connecting the eye movements, right? So, right. So I was told that there is another session, so I'll just finish it off very quickly, right? So then we have it has connections with the spinal cord to maintain the balance and the posture, and with the cerebellum as well, right? Right, so that is about the vestibulocochlear nerve. The eye movements, they are done by the 3 nerves, the third, fourth, and the sixth nerve, the oculomotor nerve. So all that information is there. Just have a, yeah. I saw there had been questions about the light reflex, the direct and the consensual reflexes, right? So, and so how it affects. So all this information is there. So you can have a look at it. I'll share it. Accommodation reflex. What happens when the 3 nerves are affected? Oculomotor nerve injury, right? You know, the oculomotor nerve has the parasympathetic fibers at the periphery and the motor fibers in the towards the center. So it will have the different type of effect depending on the area where it is affected, right? So all that is there, right? I don't have time to go through it. I'll just stop it, but I just want to show all the information that you want to know about the cranial nerves. So that is there, right? So facial nerve. So just have a look at it, right? So the how the cornea. So this is about the acoustic neuroma. And finally about the lower cranial nerve. So the gag reflex, it is there, right? And then so this is what I've been telling you about the jugular bulb tumors, right? So which affect the 9th, 10th, and the 11th nerves, right? Yeah, that's it. Sorry. I cannot do the cranial now. I thought I will not be able to have time to do this, but it is basically about remembering the facts, right? So with that, I'll just stop it, right? Because you should have at least a 5 minutes break before the next lecture. Right. So thank you so much. I've been answering the questions as you have been posting it in the chat box. I think I have answered all the questions. Yeah, so thank you so much. So that's all for me. I'll share all the lecture notes, right? And you will get it. You can have it. And if you have any questions, of course, you can get my email or the WhatsApp number from the organizers. And if you have any questions, just let me know, right? So I'll just try to help you as you go on. So thank you so much, right? I'll just stop it there, right? And wish you all the best for your all the exams and all your future endeavors, right? Thank you.
Thank you so much, sir.